Welcome to our discussion on Candida glabrata emerging as the leading cause of candidemia. This landmark analysis of 13,177 United States hospitalizations from 2016 to 2024 highlights significant shifts impacting clinical practice and antifungal stewardship. C. glabrata has overtaken C. albicans as the leading cause of candidemia in the United States, marking a historic shift. This change impacts antifungal resistance, therapy choices, and diagnostic strategies. Candidemia remains a prevalent healthcare-associated infection, linked to high morbidity, mortality, and costs, making species identification and antifungal susceptibility testing crucial. Our study used the Premier Healthcare Database, which encompasses over 1,400 United States hospitals and represents about 25% of national admissions. We analyzed 13,177 hospitalizations from 2016 to 2024 across 361 hospitals, involving at least 12,864 unique patients. The candidemia rate was 47.1 per 100,000 hospitalizations. Inclusion required Candida isolation from blood culture using International Classification of Diseases, 10th revision, clinical modification codes, billing records, and lab data. In 2024, C. glabrata became the most prevalent species at 34%, overtaking C. albicans at 32%. C. paracillosus saw a significant decline to 8%, while C. auris emerged from non-existence in 2016-2018 to 5%, becoming the fifth most common species. Candidemia rates spiked during the COVID-19 pandemic, reaching 66.6 to 67.1 per 100,000 hospitalizations. Although rates have decreased, they remain higher than pre-2020 levels. Continued monitoring is essential to manage this persistent elevation. Candidemia rates are highest among patients aged 45 to 64 and those 65 and older. Male patients experience significantly higher rates than females. Geographically, the southern United States Census region and non-Hispanic Black patients show the highest rates, highlighting demographic disparities in candidemia risk. Examining species-specific clinical differences, Candida albicans and Candida glabrata show similar crude mortality rates of around 41 to 42%, higher than those of other species at 33%. Median age varies slightly, with Candida glabrata patients being older. Diabetes mellitus is more prevalent in Candida glabrata cases, while COVID-19 co-diagnosis is notably higher in Candida albicans cases. Fluconazole resistance varies among species, 3% in C. albicans, 9% in C. glabrata, and 6% in other species. Echinocandin resistance is 1% overall, with C. glabrata as the primary driver at 3%. Notably, only 41% of hospitalizations had antifungal susceptibility testing data, indicating a significant testing gap. Candida auris has rapidly emerged as a significant threat. From 2016 to 2018, there were no cases. By 2022, it accounted for 2% of candidemia hospitalizations, rising to 5% by 2023-2024, ranking it fifth among Candida species. C. auris is often multi-drug resistant, with echinocandins as the first-line therapy. Accurate species identification is crucial. The rise of Candida glabrata is driven by broad fluconazole prophylaxis and its reduced azole susceptibility. Higher diabetes prevalence may also play a role. Candida albicans mortality remains high due to its association with COVID-19, mechanical ventilation, and its invasive growth forms. Delayed detection suggests a healthcare-associated origin. Clinicians must test every Candida isolate at the species level and perform antifungal susceptibility testing. Echinocandins are the first-line treatment for candidemia, especially with rising Candida glabrata and Candida auris. De-escalate to fluconazole only after confirming susceptibility. Implement strict infection control for Candida auris due to its transmissibility. In 2024, C. glabrata surpassed C. albicans in United States candidemia cases. C. auris rose to 5% prevalence, highlighting the need for vigilance. Only 41% of cases had susceptibility testing, underscoring the need for improved adherence to the Infectious Diseases Society of America guidelines. Echinocandins remain the standard empiric therapy, with de-escalation contingent on confirmed susceptibility.